All right, let's discuss fluid responsiveness in children in this hopefully short session. What is fluid responsiveness? This is only in the context of impaired perfusion or shock. When we are dealing with a child who is come in shock and we don't know the reason, then we have to think about fluid responsiveness, whether giving fluid to this child is going to help or not. Technical definition is that the cardiac index or stroke volume index should increase by fluid administration, and it should increase by around 10% to say that yes, this child has responded to the fluid or a positive fluid response, or we can call it a fluid responder. Some caveats have to be understood that if the perfusion is okay, despite the perfusion being okay, a patient may be fluid responsive. That doesn't mean that we need to give fluid to that patient, and despite being fluid responsive, a patient may be fluid intolerant or may develop signs of venous congestion, lung flooding like B-lines, crepitations. So that we have to understand. Fluid responsiveness, basically we are looking at stroke volume and preload relationship. So preload is this per the Frank-Starling law. As long as we are on the steep portion with increase in preload, if we increase the preload, there will be a good increase, should be a good increase in stroke volume. So whenever you see a lot of variations in various parameters by giving fluid or by mechanical ventilation induced parameters, a lot of variation in the stroke volume, probably that indicates that this patient's Frank's heart system vascular heart axis is operating in the steep portion. So you're getting these variations, and that is the principle by which we think that yes, probably this patient may be a fluid responder. So giving preload is going to stretch your cardiac muscle, and it's going to increase the contractility. That is the basic principle. So preload fluid responsiveness, by basically we are also looking at preload. So preload is basically is the venous return, and venous return, actually we cannot measure the preload directly unless we have a pulmonary artery catheter. So we take various surrogates we have discussed previously. Right ventricular end diastolic volume, we take surrogates like pressure, then RAP and CVP, and venous return actually depends upon the difference of pressures in the mean systemic filling pressure, which is the mean pressure in the venous side, minus the right atrial pressure or the CVP. So if the CVP is very high, it can actually impair your venous return pressure head divided by the resistance and the various vessels in and around the heart, which actually decrease. If it is more, the venous return will be less. Some static variables and dynamic variables, you must have read about it. So static variables measure some parameters, like single parameters like central venous pressure, single reading, a pulmonary artery occlusion pressure. On echo we can measure the left ventricular end diastolic area, and Doppler stroke volume index, corrected flow time, global end diastolic volume index. Then based on some extra pico monitors, we can use either pulmonary artery catheter thermodilution based methods or a transpulmonary thermodilution based methods using the pico and the litco type monitors. And there is the same, based on the same principles, there is the transpulmonary ultrasound dilution also, where you can give 1 ml of saline bolus and measure the difference in the ultrasound waves in the various parts, and it gives us active circulation volume, central blood volume, total and diastolic volume, and has its own applications. If in refractory shock cases, we may have to use these modalities. So static variables do not have a very good correlation on the bedside with actual fluid responsiveness. So we cannot rely on these variables. For example, CVP is the classically thought, studied and very popular variable, but it is not a very good parameter in that sense, although it has its own applications. But we have to know the limitations of using CVP for preload assessment. Although CVP does have some corroborations, and the IVC variability and IVC size does give you some idea about the CVP. So in that sense, it's not totally obsolete, but we have to know what it means. So dynamic indices are more common or more better, you can say, correlated with predictability of fluid responsiveness. In there are three categories. Basically, we have the mechanical ventilation induced changes like respirophasic. We call them respirophasic changes, and there are the preload redistribution maneuvers, different from the standard mechanical ventilation. If the mechanical ventilation induced changes in the stroke volume, the respirophasic changes, they all basically measuring the same thing, measuring the variations in either the systolic pressure, stroke volume variation by various monitors, pulse pressure variation we can measure at the bedside, ventilation induced plethysmographic variation. So plethysmographic variability index, that also comes into this. Peak aortic delta V peak, change in the peak aortic velocity, breath to breath, and delta aortic blood flow variation. And similarly, based on the same concept of mechanical ventilation induced variation, but there are some non-stroke volume derived parameters. For example, respiratory variability of the IVC and SVC. Here we are not actually measuring the cardiac output, but it has to be understood that these are also dependent upon the mechanical ventilation induced changes in the stroke volume. So the limitations which apply to the applicability of these parameters also apply to these parameters. And there is also the left ventricular pre-ejection variation. And among the preload redistribution maneuvers, which are different from standard mechanical ventilation, we have PLR induced changes in cardiac output. So basically PLR always has to be done in, and we have to measure cardiac output also. And respiratory systolic variation test and expiratory occlusion test, they are all measuring the mechanical ventilation induced changes in the preload and Valsalva maneuver. How these things works basically in positive pressure breath, we are increasing the pleural pressure and increasing the transpulmonary pressure. We are directly measuring increasing the pleural pressure, which is directly decreasing your right ventricular preload, and increasing the right ventricular afterload by increasing the transpulmonary pressure. So RV function is compromised. So RV is not getting good preload is getting decreased, and afterload is getting increased. So ultimately RV ejection is getting decreased. This is the most important thing. After a few breaths, so why with this decreased RV ejection, what is happening on the left side is that because of this increase in pleural pressure, left ventricular afterload is decreasing. So left ventricle can basically contract, is getting some help in contracting ejection. So LV afterload is less, and LV preload is also less because transpulmonary pressure, some squeezing of pulmonary vessels is happening. So preload is also increased. So with the immediate impact of the positive pressure breath is that your pulse pressure is maximum, or your stroke volume systolic pressure is maximum with the inspiration. However, after a few seconds, this decrease in the RV ejection is going to reach the left ventricular side. So LV preload is going to decrease and LV ejection is ultimately going to decrease after a few seconds. This drop in this will lead to a drop in the LV ejection. So pulse pressure variation, pulse pressure, systolic pressure, all these parameters will be least by the time this time is reached out. This happens usually by the time of end of expiration. So usually with inspiration, the direct impact is a maximum pulse pressure, followed by the time of end expiration there is a drop. If we are getting significant swings, so if our vasculature or IVC or the heart is operating at the steep portion and your patient is not adequately filled or IVC is not filled, it is this mechanical ventilation induced changes in pleural pressure and transpulmonary pressure will be more. If your IVC is collapsing or your vascular volume is less, then these changes will be more. So if you give them fluid, these changes will be less. The amount of variability, if it is significant and based on various parameters, that becomes a good indicator of fluid responsiveness. So these pulse pressure maximum pressure based changes in the respirophasic changes in the pulse pressure, like pulse pressure, systolic pressure, they have been found to be very good predictors of fluid responsiveness in adults. These parameters have not shown to be a very good predictors of statistically proven predictors of fluid responsiveness in children. So there can be various reasons for that. Is that basically the chest wall, increased chest wall compliance, and the compliance of the vasculature So a lot of reasons are there. So mechanical, relatively less tidal volumes. All these changes, reasons have been postulated why these pressure-based changes in the respirophasic variables do not actually give very good statistic correlation of fluid responsiveness in children. Needlessly, we have to understand this, the concepts of this. So when we are looking at studying a pulse pressure or a systolic pressure variation, we can study three things. There is the systolic pressure maximum inspiratory, that's the systolic pressure minimum expiratory. So we also study two things, delta up and delta down. From suppose we are taking an apneic baseline, suppose patient the normal, you can say static or normal pulse pressure or blood pressure. With apnea, when you give the pressure, positive pressure breath, there will be a maximum increase in the pulse pressure, systolic pressure maximum. This increase from the apneic baseline is delta up, followed by there is a minimum at the end of expiration. Compared from the apneic baseline, this minimum is, this distance here is delta down. So this delta up and delta down is also shown good correlation with fluid responsiveness in adults. So this is the formula, these are the way we can actually quantify it. Pulse pressure maximum plus minimum divided by the mean, and similarly systolic pressure variation maximum minimum divided by the mean. So pulse pressure usually around 10 to 13% is said to have a good correlation with prediction of fluid responsiveness. Another important concept is this end expiratory occlusion test. So here what we are doing is we are giving an end expiratory occlusion, like when measuring intrinsic PEEP, we give an inspiratory hold. That's what we're going to do. And sorry, like when we are doing this intrinsic PEEP, then we are giving end expiratory hold. So we have to give at least a 15 centimeter end expiratory hold. It is going to decrease the next, basically at end expiration, at the minimum level of the pulse pressure, you are stopping the next positive pressure breath. So next ventilation induced changes, the drop in the blood pressure or the variation will not happen. So your preload will reach its maximum because the further drop in the RV preload is not going to happen. So you get some increase in the stroke volume. But the problem with this is that the amount of change, when we give this inspiratory hold and we measure the change in the cardiac output by using, say, delta VTI or some cardiac output measurement device. The issue with this end expiratory occlusion is that the amount of change it produces with a typical end expiratory occlusion is only about 3 to 5%, and that is mostly the, you can say, error range in a standard measurement of cardiac output. So you cannot be very sure that it has actually produced very good, it has been effective. So recently some authors have tried combining this end expiratory occlusion with an inspiratory occlusion. So before fluid administration, when some end expiratory occlusion is done, so you get an increase in VTI, followed by end inspiratory occlusion. Because we are stopping here at end inspiration, so opposite is going to happen. Your pulse pressure or VTI is going to decrease. Then again after fluid administration you measure it. This delta change from starting from a baseline, then end expiratory increase followed by end inspiratory decrease, this whole change comes about to be around 10 to 12%, which is well within the range of the measurement that can be the change which can be measured comfortably or accurately with the cardiac output measuring device. So the combination of end expiratory and end inspiratory occlusion is being tried nowadays. Another important or newer concept is the tidal volume challenge test, because all the mechanical ventilation induced pressure variation based indices like pulse pressure, systolic pressure, stroke volume variations have the limitations that you need to have an apneic patient with no arrhythmias with good tidal volumes of around 8 ml per kg, because you need 8 ml per kg change in the lung volume to cause some impact on the filling of the heart. If you get very small tidal volumes, probably the change produced is not effective. So what they postulated that You can measure the pulse pressure at 6 ml per kg, then you can transiently increase it to 8 ml per kg for a few seconds. Then you measure the delta ppv. This delta pulse pressure variation of around 3 to 4% may be a very good predictor of fluid responsiveness. So they found a lot of studies, have even some studies from Tata Memorial by adult intensivist Dr. Sheila have happened, and also a lot of authors have done intensive care that it can be used. So both delta ppv and delta ppv percentage have good predictability. Delta pv is recommended first, and they say also that it can be used. It is not that much influenced by low lung compliance and moderate PEEP measurement devices, which are the standard limitations of the classical respirophasic or pulse pressure variations and systolic pressure standard. So you can look at the delta ppv, the change, the pulse pressure variation measured at 6 ml per kg versus the pulse pressure variation measured at 8 ml per kg, T2 minus T1. This delta may be a good parameter to be looked at when we are looking at these parameters. So coming to IVC, let's see first how to measure IVC. Whenever we are trying to look at the variation in the IVC, it should also be always be measured longitudinally. We should look at the probe should be not at an angle. We should try to be just perpendicular to the IVC. It should be measured around 2 centimeters, just around the opening of the hepatic vein into the right atrium to avoid errors. And here we can put the pulse wave signal at the IVC, and then you can use the M mode signal. This will give you that's a lot of variations, inspiratory, expiratory, with the inspiration and expiration based on whether the patient is breathing spontaneously or on positive pressure ventilation. There will be changes in the IVC sizes. So with the spontaneous breathing, you get collapse of the IVC. So you more than 50% collapse basically means that usually it correlates with a CVP of around 2 to 3 mmHg on a lower side. If you get a sick patient initially in the ER, if you do an IVC assessment, because it's a common, very popular assessment method, maybe because it's easier to access it, quite exposed. So IVC, if you get a lot of variability in a spontaneously breathing child, say more than 50% variability, or collapsibility index is around 30 to 50%, and you get a dry lung, you can look at the ultra lungs also. There's no cardiomegaly on the X-ray and your lungs are not showing any B lines probably, and your patient is actually impaired perfusion is there. In that case, probably fluid may be given, fluid may be tried safely. And if you get no variation, IVC is already more than 2 centimeters and already having B lines, probably be a bit more careful. Look at the heart function very carefully. You may be in need of starting inotrope early. Various IVC diameters can be, looking at the M mode, you can measure inspiratory, expiratory sizes. That is how it is measured. Where the indices are collapsibility index, here we look at the maximum minus minimum divided by the maximum, and the distensibility is maximum minus minimum divided by the minimum. So in collapsibility of more than 30 to 40% probably suggests lower CVP on the lower side. It's not a very good parameter of fluid responsiveness as such in children. Distensibility index in adult studies and a lot of studies in mechanically ventilated patients, around 18%, has been found to have good correlation with fluid responsiveness. For SVC collapsibility, the problem is that you have to do transesophageal Doppler. So SVC is opposite. So in a mechanically ventilated child, SVC is going to collapse. And SVC collapsibility index of more than 36% has a AUC of 9.99 for predicting fluid responsiveness, mostly in adult studies. Recently, one study by AIMS Dr. Juma Shankar, they looked at 37 mechanically ventilated children, 26 median delta IV. They looked at delta IVC and delta V peak, the change in the peak aortic velocity, and the delta IVC. So they found that the delta IVC was around 23% at a cutoff of delta IVC to predict fluid responsiveness was 23%, and delta V peak was 11.3%. So delta IVC which is slight variation here with here using formula IVC max minus minimum divided by the mean of the IVC. So that is the delta IVC. I think this formula in here denotes, actually incorrectly written, collapsibility, denotes the delta IVC. So actually around 23% has a good sensitivity, and also delta V peak, which has also been corroborated in other studies, that it is a good change in the peak aortic flow velocity breath to breath, has a good predictability, good value for predicting fluid responsiveness. Delta V peak aortic velocity is again is your maximum with the inspiration peak, delta V peak maximum minus minimum divided by the mean. So around 7 to 20% has been found to have a good correlation with fluid responsiveness. The limits of these respirophasic variables are that you need to have a low heart rate to respiratory ratio. A very high heart rate may not be good. Irregular heartbeats, arrhythmias should not happen, because if these happen, any arrhythmia is going to interfere with your ventilation induced changes in the right ventricular preload. And mechanical ventilation with low tidal volumes is not going to impact the intrathoracic pressure too much. Increased abdominal pressure is also going to limit the changes. The open thorax is going to totally diffuse the pressures. So pressure changes will be totally opposite. And spontaneous breathing is, obviously we are relying on the fact that this positive pressure breaths are impacting tidal volumes and preloads in a certain manner. So any spontaneous breathing, if the patient breathes spontaneously during this or performing these tests, then this will not be effective. So the redistribution maneuvers, preload passive leg raising test is one test which can be done. It is independent of the ventilation induced changes. So it's basically a preload distribution maneuver. In adults, some mini fluid challenges also has been tried. So they give 200 to 300 ml. Minimum fluid challenge that you can give is around 4 ml per kg to cause a significant shift in the pressures on the venous side to cause some increase in the preload. Here in PLR, without starting from the semi-recumbent position, you measure cardiac output at baseline, then without touching the patient, change the bed and make the patient Trendelenburg position and use a real time. Do not cause any pain or do not disturb the patient too much. Change the position. It is going to give an auto transfusion of around 100 to 200 ml, depends on the age and the length of the height of the child. And then you again at this position. From this position you do the PLR, measure cardiac output again. Look at the cardiac output. If it is increases by 10 to 15%, probably it will be a good marker. Then you again return the patient to baseline, and to complete it, the cardiac output should return to the baseline at which we started with, at the semi-recumbent position. Here it is important to know that you don't touch the patient. Do it simultaneously. The changes. Use the remote of the bed and probably explain to the patient, depending upon situation, and use a real-time measurement of cardiac output. You can use suppose a non-invasive cardiac output monitor is there, you can use that, impedance cardiometry or electrical cardiometry based devices, or you can do delta VTI, delta V or delta V peak to get an idea of the change in the cardiac output with PLR test. It is not that effective in smaller children less than 5 years because volume shifts are less, so lower extremities do not hold that much blood volume, so auto transfusion will not be that much. This is just the summary of all the changes taken from an adult book. So pulse pressure stroke volume variation threshold is 12%. Limitation is, as I told you, no spontaneous breathing, cardiac arrhythmia, it will not be effective. Tidal volume challenge of 2.5 to 3% for pulse pressure or 2.5 for stroke volume. It also has the same limitations of cannot be used in case of spontaneous breathing, cardiac arrhythmias. IVC diameters 12%, depends which parameter you're looking at. SVC variation 36%. PLR 10 to 15% change of cardiac output should be there, and expiratory occlusion has a threshold of 5% but falls within the error. So combined with suppose and inspiratory occlusion, you can get a change of 10 to 15% of cardiac output, which is easier to measure without much errors. Many fluid challenge tried in adults 100 to 200 ml. You should not be using too much fluids because ultimately you're going to cause fluid creep, and if you keep using fluids, it's going to accumulate. So in summary, in spontaneous breathing we have PLR. You can use PLR. We can use IVC collapsibility index if it's significantly high, 50%, along with the dry lung, probably you can, and hypercontractile, you can look at the heart. If it's hypercontractile, probably you need fluids. Various signs are there, we'll just discuss briefly. And in positive pressure breathing, you have limited options, you can, which have good corroboration, like delta V peak and delta IVC and PLR based tests. This algorithm, so based on fluid responsiveness, first of all, the question will arise only when we don't have any clear-cut history. If you have a clear-cut history of hypovolemia, like hemorrhage, hypovolemia, loose stools, diarrhea, you're not worried too much. You're probably, obviously, you're going to give fluids. The question arises in a case which is not clear, like septic shock. You don't know the cardiac output, BP is low, child may be cold, CFT may be prolonged or flash refill, but this doesn't correlate with actual hemodynamic status. So if your signs of overt hypovolemia are there, like small LV, hyperdynamic LV, EF is good, walls are kissing, hyperdynamic heart, and based on eyeballing, RV is small, IVC is small, and lot of variation. So probably you can give fluid challenge, and you measure VTI or stroke volume before and after fluid challenge to ultimately see if fluid stroke volume increases to around 15%. Yes, then again that will be your marker that yes, this patient is fluid responsive. If there is no increase in VTI, then do not give further fluid. Also assess for other causes, LV-RV failure, any tamponade, any obstructive shock, and false negatives can be there. If your increase in E and E to A variation will fluid challenge or PLR to ensure that preload has increased. These are the cardiac echo-based parameters of RV function. Then if these overt hypovolemia, these signs are absent, then if the patient is invasively ventilated, sinus rhythm, tidal volume good, more than 8 ml per kg, no spontaneous breaths, then you can variation of aortic break flow velocity, IVC respiratory variation around 12 to 13%, V peak, then probably fluid can be tried. And if the patient is spontaneously breathing or arrhythmia or spontaneous breaths, then these parameters, these ones cannot be used. So we'll look for we'll do PLR and measure delta VTI before and after PLR. If it is more than 15% change, probably fluids can be tried. So that was the whole brief summary of fluid responsiveness, maybe some errors and all, but just a quick overview of fluid responsiveness. A lot of things to be studied, and actually very important and practical day-to-day importance topic for all ICU physicians and all the critical care doctors. Thank you.